Hi, welcome to Good Nurse. I'm Nurse Ashley, and today we're tackling a topic that shows up often on the NCLEX, managing fluid and electrolyte imbalances. Remember, this content is for educational purposes only and is not a substitute for professional medical advice. By the end of this video, you'll feel more confident interpreting common imbalances, understanding their causes and effects, and knowing which interventions the exam wants you to prioritize. If you've ever struggled with memorizing electrolyte values, don't worry. We're going to focus on patterns, rationales, and test-taking strategies so you can handle these questions with ease. On the NCLEX, fluid and electrolyte questions often present a scenario of a patient with vague symptoms. Maybe they're weak, they have muscle cramps, or they show changes in their mental status. Your job is to connect the dots. Is it hyponatremia, hyperkalemia, or perhaps dehydration? The exam wants you to think critically about what's causing these imbalances and what the safest intervention is. It's not just about remembering the normal lab values, it's also about understanding the why behind the changes and choosing an action that improves patient safety and outcomes. Let's start with fluid imbalance. The NCLEX might give you a patient who's been vomiting for 2 days, has dry mucous membranes, and low blood pressure. Immediately, you should think possible dehydration or hypovolemia. In this case, your priority intervention might be to start IV fluids to restore their volume. On the other hand, a patient with heart failure who gained 3 pounds overnight and has had difficulty breathing might have fluid overload, indicating the need for diuretics or fluid restriction. The exam tests your ability to recognize these patterns, so always consider intake and output trends, daily weights, and signs like edema or orthostatic hypotension to guide you when you're trying to determine what the patient's fluid status is. Electrolytes can feel overwhelming, so let's break down some key players. First, sodium or Na+. Normal range is about 135 to 145 milliequivalents per liter. Hyponatremia can cause confusion, weakness, and even seizures if severe. Think of situations like excessive water intake, SIADH, or prolonged vomiting. Hypernatremia often presents as thirst, dry mucous membranes, and altered mental status. On the NCLEX, a patient with hyponatremia might need fluid restriction or hypertonic saline if severe, while hypernatremia might require careful rehydration. Next is potassium or K+. Normal is around 3.5 to 5 milliequivalents per liter. Hypokalemia can show up as muscle weakness, cramps, and dangerous cardiac arrhythmias. Causes include GI losses like diarrhea or diuretics. Hyperkalemia can also cause arrhythmias, along with muscle twitching or weakness. The exam might present a patient with a potassium-sparing diuretic with peaked T waves on the EKG, prompting you to think hyperkalemia. Management often involves stabilizing the heart with IV calcium gluconate, shifting potassium into cells, insulin with glucose, or removing it from the body, which is things like diuretics or dialysis. Next is calcium, Ca2+. The normal range is about 8.5 to 10.5 milligrams per deciliter. Hypocalcemia can cause neuromuscular excitability. Think of Trousseau's sign or Chvostek's sign. Hypercalcemia might present as lethargy, bone pain, or kidney stones. The NCLEX could also ask which symptoms you'd expect with hypocalcemia or which interventions help lower hypercalcemia, like increasing fluids or administering calcitonin. Remember these neuromuscular signs as the exam loves to test them. Next is magnesium, Mg2+. Normal is about 1.7 to 2.2 milligrams per deciliter. Low magnesium often mimics low calcium with neuromuscular irritability, while high magnesium can lead to diminished reflexes and respiratory depression. If a patient with preeclampsia is on magnesium sulfate and becomes lethargic with low reflexes, you should think magnesium toxicity and consider stopping the infusion or giving calcium gluconate. Phosphorus, phosphate, and chloride, These are less commonly tested as primary imbalances on the NCLEX. Understanding that they also affect cell function is very helpful. Usually you'll see them mentioned in the context of other conditions like malnutrition or chronic kidney disease. The NCLEX may also integrate fluid and electrolytes into larger conditions. For example, a patient with diabetic ketoacidosis might have dehydration and electrolyte shifts. Someone with CKD could have hyperkalemia and hyperphosphatemia. The exam wants you to pick interventions that stabilize the imbalances, like giving IV fluids, correcting blood glucose, or using dialysis if necessary. Now let's consider some practice questions to deepen our understanding. I'll read a scenario and possible answers, give you a moment to think, and then explain the rationale. Practice question 1. A patient has been vomiting frequently for 3 days and reports feeling weak and dizzy. Their blood pressure is low, pulse is elevated, and they have poor skin turgor. What's the best initial intervention? A. Restrict fluids to avoid overloading them. B. Administer IV normal saline to restore volume. C. Give an antiemetic only and reassess later. D. Offer sips of water and wait until they tolerate oral intake. The correct answer is B. These signs point to dehydration or hypovolemia. The NCLEX wants you to recognize that prolonged vomiting leads to fluid and electrolyte losses. IV fluids help restore circulating volume and improve blood pressure and perfusion. Restricting fluids or just giving antiemetics isn't enough if the patient is significantly volume depleted. Oral sips might not be sufficient in moderate to severe dehydration. Okay, practice question number 2. You're caring for a patient on a loop diuretic who now complains of muscle weakness and is found to have a potassium level of 3.0 milliequivalents per liter. What's your priority action? Ask the patient if they've been eating enough bananas. Hold the diuretic and notify the provider about the hypokalemia. Increase the IV fluids to flush out the system. Reassure the patient that this is a normal side effect. The correct answer is B. A potassium of 3 is low, and diuretics like furosemide commonly cause hypokalemia. Muscle weakness can progress to cardiac arrhythmias, so it's critical to address this. Holding the diuretic and notifying the provider may lead to orders for potassium supplementation. Suggesting dietary changes like eating bananas could help long term, but it really doesn't address the immediate risk. Increasing IV fluids won't fix the underlying potassium loss, and you never reassure a patient that abnormal labs are normal. So let's go on to practice question number 3. A patient with chronic kidney disease has a potassium level of 6.2 milliequivalents per liter and shows peak T waves on their EKG. Which intervention should you anticipate? A. Administer IV insulin with dextrose to shift potassium into cells. B. Encourage the patient to eat high potassium foods to stabilize levels. C. Apply a warm compress to improve circulation. D. Tell the patient to take deep breaths to reduce potassium. The correct answer is A. Hyperkalemia with EKG changes is an emergency. Giving IV insulin with dextrose helps shift potassium from the bloodstream into the cells temporarily, stabilizing the heart rhythm. The NCLEX wants you to recall the steps for acute hyperkalemia management, encouraging high potassium foods, using a warm compress, or deep breathing do not correct life-threatening hyperkalemia. These questions really illustrate the NCLEX's focus, recognizing clinical signs, interpreting lab values, and acting promptly to prevent complications. Fluid and electrolyte imbalances can escalate very quickly, so prompt, correct interventions are vital. As you study for the NCLEX, focus on understanding cause and effect relationships. If a patient loses fluids through vomiting or diarrhea, think dehydration and electrolyte depletion. If a patient has kidney issues, consider hyperkalemia and fluid overload. If you see specific EKG changes, muscle twitching, or confusion, link them to an electrolyte that commonly causes those symptoms. Memorizing ranges is helpful, but Understanding the clinical picture is what sets you apart when choosing the right answer. Also, be aware of safety steps. If potassium is low, you don't give it IV push. Never forget that. If sodium is extremely low, correcting it too quickly can cause neurological complications. The NCLEX may test your knowledge of safe correction rates and methods, and always think, what is the safest intervention that aligns with standard nursing practices? Remember, the exam cares about patient safety and prioritization. If two answers seem correct, pick the one that protects the patient from immediate harm. Stabilizing airway, breathing, and circulation is always key, and restoring normal fluid and electrolyte balance supports all bodily functions. Watch for subtle cues in the stem, like sudden changes in mental status or EKG changes, and choose actions that directly address those urgent problems. By consistently reviewing fluid and electrolyte concepts, practicing NCLEX style questions, and thinking through rationales, you'll build the confidence to tackle even the trickiest scenarios. Understanding the pathophysiology behind electrolyte shifts and fluid imbalances helps you predict what the patient needs before it becomes an emergency. Thank you for watching Good Nurse. If you found this video helpful, give it a thumbs up and subscribe for more nursing tips tailored for the NCLEX. I'm Nurse Ashley, and I'll see you in the next video where we will break down another complex concept into manageable steps that set you up for exam and clinical success. Bye.